Michael? I guess we're not, Michael, nothing's happening? All right.
You have quick access to CRM. Can you call Omnicare?
Okay, let me give him a call.
Okay, thanks.
Yeah, I have it. Let me give him a call. Stand by, Kay.
Perfect. Thank you.
Okay, he's just made it back to the office. He's going to be logging in the next 2-3 minutes.
Okay, fantastic. Let me go ahead and go back to the first screen of my PowerPoint and share it. Omnicare this is our Omnicare with, Alex Saldana?
No,
Is that
this is
accurate?
Mike Maglonso, the owner.
Okay.
I'm not sure if
Yeah.
Alex Saldana is part of this agency.
Yeah, no, I think I got my agencies mixed up. But Omnicare is
okay.
one we're currently doing coding for. That's what I was thinking of, so. Or at least
Yeah,
we were
Melinda
last time I looked.
Yeah, Melinda put that Mike is the owner, and then in her notes below, she said Arun is the owner.
Yeah.
And Mike
Yeah, I've
is
talked to
her...
Arun before.
Okay.
I've talked to Arun before, so. But essentially, they're clients of ours, so this is something Janelle's already kind of preparing them for, so we won't get a sale out of this one. But also know that since we're chatting before the event, like with James, there's a couple of the videos we can't share with people unless we're going to scrub them and edit them, because we record right away. So we did the same thing with the one on Tuesday morning. We had a call with somebody. Can't remember the agency's name. Did the same thing Tuesday afternoon. He got on the phone very initially, and this first one, he's like, "Oh, well, call me at my cell number," and he provided on the recording. And then the second one in the afternoon, when you were, at the airport, because it was 2:00 Pacific, you were at the airport, or already boarded. At the very beginning, he's like, "Well, what I'd like to do for this call is," I'm like, "Okay." He's like, "Why are we recording it? Nobody's ever going to watch it. We shouldn't be sending that to them."
I agree.
So I haven't been sending it to him. So
are we okay not to?
Michael's joining or has joined. He's not on the phone. So I agree, yes. I think so as well. Let me go and share my screen. Looks like they are joining. Participants. He's just not on audio yet. Hey, Michael. This is Michael with Healthcare Synergy, and Ed Lean's on the phone with me. If you don't have a microphone, you'll want to join by computer audio, please go ahead and choose the option to dial in, make a connection. When you go to the Zoom window, you have the option of choosing leave computer audio, and then clicking on the little headsets that show up and dialing the phone number.
Hello?
Hello, Michael. How are you doing today? This is Michael with Healthcare Synergy.
Hi, I'm doing well, thank you. So sorry about being late. Just needed to go drop off some supplies to a patient this morning.
That's quite okay. We need to take care of patients. That's the whole reason we're in business, so don't apologize. Thanks for joining us.
Thank you. Thank you.
We'll go ahead and let Ed Lean kind of get the call started.
Okay, well, thank you so much for joining us today, Mike. So it's our understanding you're looking at information for PDGM, correct?
Yes.
Okay, great. And just before we get started, I wanted to get a little bit of information from you. Who is currently doing your coding?
Coding, it's one of our employees. Her name is Samantha.
Okay, and how is Samantha doing with the coding? Are you guys pretty satisfied with her work?
Yes.
Okay, great.
Yeah, she's actually our OASIS reviewer and coder at the moment.
Okay. And we're roughly sitting on a little bit over 100 patient census at this time?
No, we've dropped down a bit. We're about hovering a little over 60 at the moment.
Okay. And it looks like you guys are also using Synergy EMR. How's that working out for you guys?
It's working out really well.
Okay, awesome. Well, I'll mention it again before the end of the call, but we also have a PDGM functionality demo that we're going to be doing I believe the date is on October 23, and what I could do is I can send that to both you, Samantha, and do you have a biller right now as well?
We do. They're actually a third party. We don't do our own billing in-house.
Okay. So what I can do is I can send you and Samantha the registration link for the functionality demo. Like I said,
Okay.
it's on October 23, but we can go ahead and tie that in later on after we do the overview for you. Okay?
Okay, perfect.
So without further ado, I'll go ahead and let Michael begin.
Thank you.
All righty, Michael. I am the clinical manager here at Healthcare Synergy. I oversee our outsourced OASIS review, our coding services that provide a 24 to 48-hour turnaround, help maximize your reimbursement. All of the work we do is through licensed clinicians that are certified both in OASIS and coding. So that's kind of the background for myself. I also maintain knowledge on the CMS regulation, the changes that they have. I advise our software development team so that they can add as much functionality as possible into the CMR and the Synergy in the Cloud software to make it as functional and robust as possible, automate a lot of your steps and the processes. Cecile Sinisa works and does our chart review service. So we have a chart review service with the goal of helping you be survey ready every day. We do that by reviewing 100% of your documentation real time. While the case is current in everybody's mind, the clinicians are still at the agency, and if any changes need to be done that would become a survey deficiency, they can be addressed real time, and you don't have to worry and stress when a survey comes, when an ADR or a Target and Probe and Educate hits the agency. We also have Cecile Mercado, one of our specialists in billing. She oversees our billing and revenue recovery service. And the goal of that is to do timely billing currently, as well as the revenue recovery service reviews your historical charts before that timely billing period expires, 6 months to 12 months usually, to see if there's any way they can recover money through missed visit notes, through canceled reps that never get billed as final claims, through outlier payments, and so on. They review that. If they're able to recover money for you, they take a small percentage of that. If they're not able to recover any money for you, then it's just a healthy checkup. You don't pay anything for that particular service. So I always call that a win-win, because you get a checkup to see if you're missing any money, and if so, they help you recover that and rebuild claims and such. If not, then you simply got an A+ on your report card, and they don't charge you anything for it. So it gives a little bit of background of what we do, what my role here is Healthcare Synergy is. The PDGM itself, a lot of people have heard 30-day payment period. Their questioning is, the episode changing to a 30-day period, is it going to stay the same, and so on. The COP requirements are not being changed at all. That means that the 60-day period is still going to happen. You're going to have a 60-day episode for your patient. You'll still do starts of care and research on the current schedule. That is not changing at all. What is changing is the payment period. So essentially your biller's work is going to be doubled, because you're submitting 2 reps and 2 final claims in that 60-day period. You have a first 30-day period, day 1 through day 30, and a second payment period, day 31 through day 60, depending on whether that patient's still on service or not. So that's the biggest change with PDGM that affects the staffing of the agency and what they're performing. Payment considerations, the case mix model, and feel free to ask any questions if you have those as we go through the presentation. You don't have to hold those because there's a chance you're going to forget those. Go ahead.
No problem. On the 30-day payment period, we've heard about this part over here. One of the things we had a question about was, how do we prove that second rep? Usually with a rep, there has to be an OASIS visit that has to be exported out, plus the first billable visit. So for day 31 through 60, how does that happen without another OASIS?
It is not another OASIS unless you wish to do another follow-up. Day 31, you still have the same requirement for a first billable visit in that period before you can send the wrap off. So if you do a billable visit on day 31, you certainly could wrap, a couple of days after that, or 32nd through the 35th, whatever day that first billable visit, that would be the requirement for that. Your case mix information is going to come from the SOC or the recert that started the first 30-day payment period, unless you've done an other follow-up or an ROC. So it is possible you will have a different OASIS assessment than what started the 60-day episode. But your claims is going to have the diagnosis codes from your plan of care. So if you had a supplemental, a change in orders, a change in your diagnosis coding sequences, new diagnosis codes, then that could affect your case mix model. Your ADL questions we're going to talk about in the presentation, but if you have a new OASIS, then that could change your case mix model as well. But you don't have to do another OASIS to answer your question. You certainly can, but it's not a requirement.
Okay.
So the values that go into the case mix model itself is the timing of the care for home health for that patient. Typically, it's a brand new SOC for you, therefore it's a brand new episode of care for that patient. If they came to you from another agency, you would receive that patient as a later instead of an early, simply because it's from the patient's perspective if they've had previous care. So that will be one of the things that your biller, typically, possibly your intake staff would do, is check the common working file to see where they're at. The admission source, where that patient came from, is a component of that case mix model. The other three components are your diagnosis codes, your primary diagnosis code, and your secondary diagnosis codes. The claim itself is going to allow up to 25 diagnosis codes. It already does, but a lot of agencies aren't putting that many codes on. So from code 2 through 25, 24 total codes are what are called your secondary diagnosis codes. Those can have a comorbidity adjustment on those. Those are all taken from the claim itself. So you're familiar probably with the OASIS assessment. It only has 6 diagnosis codes on it. The rest,
right.
All of these are now going to come from the claim itself. Your functional questions is going to be 1033, 1800 through 1860 are those deciding codes then. The timing of it can either be an early or a late. Again, it's from the patient's perspective. So if they've not had home care for 60 plus days, they'll come to you as an early patient. Otherwise, they're going to be seen as a later patient. You'll still answer M110 on the OASIS assessment. That will still be a 60-day window, or 120 days. First 2 episodes would be an early, but that is not how they're paying you now. That question essentially is kind of going away. It's no longer important. It doesn't factor into the case mix.
Okay.
The patient itself can be institutional or community, depending on where they come from. These are going to be based on 30-day windows. So the left side is your institutional. That counts for your 60-day, or for your first 30-day period coming from for a new SOC. So if they came from an acute care hospital, they are always institutional. If they came from an inpatient psych, nursing, rehab, or long-term care facility, all of those on the SOC first 30-day period only is going to be seen as institutional, which means you get paid more. If they are community, being that psych, nursing, rehab, or long-term care on a second or later 30-day period without a discharge, they're going to be seen as a community, which means you get paid less for those. So what that means is that the first 30-day period in your SOC assessment is typically going to be an early institutional. Thereafter, that second 30-day payment period, even though it's the first 60-day episode, is going to drop to a later payment and a community payment. There is no way to go from early or from late back to early unless you discharge and readmit that patient. You can go from a community back to an institutional if that patient's gone into an inpatient facility, specifically an inpatient acute care hospital. If they go back into a skilled nursing rehab or rehab because they need additional therapy, they need additional wound care, they're non-compliant at home and their wounds aren't healing, they're not improving in therapy, so the doctor feels an inpatient setting may be better. Without a discharge, that patient would stay a community referral, so there would not be an increase in those kind of cases when they come back to you. That's probably going to be the biggest hit and biggest decision for a lot of agencies. Do we continue to transfer that patient without a discharge and wait for them to come back, or do we discharge them and have them come back as a new SOC. That is the only way you're going to be able to see them come back as a institutional from a rehab or a skilled nursing facility, a long-term care facility. So that is one of the decision factors that you have to do internally as far as policies. What are we going to choose to do from that perspective? Your primary diagnosis code, there are 87,000 valid diagnosis codes. CMS has looked at those and narrowed that down to 43,000 diagnosis codes they think are valid for initial primary care service for an agency. If your primary diagnosis code does not fall in those 43,000 codes, which are broken down into 12 groups as shown on the screen, then they will return that claim back to the agency for recoding. Possibly that means you need to requery the physician to get additional information from that particular process. A lot of the changes currently are required around what CMS, like I said, sees as homebound. So muscle weakness is currently a major code, a very frequent code that's utilized by agencies when they get a referral for a patient with pneumonia or COPD, CHF. Those particular scenarios, they say, hey, the patient has muscle weakness, agencies code that as their primary diagnosis code. That will be seen as what's called a questionable encounter and will be returned to the agency because it's not one of those 43,000 valid diagnosis codes. Instead, your agency is going to have to query the physician. Your coder is going to have to ask, what is the reason this patient has muscle weakness? And that's going to be your primary. So it could be CHF, COPD, Parkinson's, hypertension, whatever, an infection like pneumonia that is current and still active. That might be a value that's coded as your primary. But just realize that the coding now is the supreme item of concern because it affects 3 out of those 5 components of your case mix. This is a list of what those 43,000 codes fall in, how they are sorted and aggregated. A lot of patients, a lot of agencies feel therapy is no longer being paid because that's now no longer a factor in your case mix. It's now a bundled service, just like skilled nursing and social worker have been for a very long time. So whether you do 2 therapy visits or 20 therapy visits, your case mix is not going to change at all. So because of that, a lot of agencies say, well, CMS doesn't want to pay for therapy, and that's not the case. The very top 2 rows, musculoskeletal rehab as well as neurostroke rehab, are 21,000 of those 43,000 codes. So it's very clear based on the diagnosis codes and the disease process that CMS is still willing and sees that as a valuable source of services for the patient. And that's almost half of those total codes. The others are cardiac issues, endocrine issues, GI, respiratory, after care for surgical issues, and so on. But this is on the far right, gives you the total of how many of those diagnosis codes make up that category from that 43,000 codes. The comorbidity adjustment is the third or the second of the 3 components that your diagnosis codes have a factor or an impact on. The comorbidity can be no adjustment at all, a low adjustment when a single diagnosis code is present on the diagnosis code list of comorbidities, or a high when 2 or more diagnosis codes are present that are known to interact with one another. You can have a none, low, or high. You won't have a combination of those. You won't get 1 low and 2 high, for example. You're going to get paid for one of any of those 3, and the highest is what you'll receive. There are no diagnosis codes necessarily that pay more than others. CMS has said that if you have a single interaction between 2, you'll get a high. If you have 2 or more of those, you're still getting a high. It's still exactly the same number of points. So it doesn't matter which of the, which interaction you have. If you have 2 or more of those, it still just counts as a high. The functional impairment, you're going to have a 1033, risk for hospitalization, 1800 through 1860, with the exception of 1845, which that one question doesn't count, that are going to give you functional impairment points. So you'll either get a low, medium, or high adjustment from that. It's important to understand that the threshold for those point ranges is determined based on the primary diagnosis category. So one of the categories is behavioral, another is endocrine, and so on. Your point ranges 0 to 35, for example, for behavioral, determines that you're in a low if you have 0 to 35 points. If you have 36 points or higher, you're in a medium. Your functional rehabilitation, your muscular rehab, the range for that particular one is 0 to 33, I believe. So even though you have exactly the same points from 1033, 1800 through 1860, because your primary diagnosis code, you're now in a medium with 35 points versus with the behavioral, you're at a low. So that's key, and that's the third component to why diagnosis coding is so imperative in your case mix model itself. The national payment rates for a 60-day episode, you'll still be paid for those for any episode that starts between November 4th through December 31st in 2019. That episode would end, the 60-day period, would end roughly February 4th. I apologize, around March 1st for that period, but that's going to be paid as a 60-day episode. Your basic standard case mix in the proposed rule is $3,221 before any wage adjustment for your area. The 30-day period is going to be for any episode starting RECERT or SOC on or after January 1st, 2020. Those are now going to be submitted as your RAP and your final claim for each of those 30-day periods. You're going to be paid a base rate in the proposed of $1,791. Below that, I have in bold $1,612 because that's going to be the standard episode rate based on the proposed rule and a 10% reduction in payment. That 10% comes from a 2% sequestration and an assumption that CMS is making currently in the proposed rule for agencies gaming the system. They're anticipating that, and they are building that in without any proof, unfortunately. So you would have a 10% reduction to that standard amount of $1,612 is what your base 30-day payment period would be, multiplied by your case mix and then any wage adjustment. So your payment could be much higher than that, depending on your cost of living in your area. LUPA ranges, right now everybody knows a LUPA is 4 or less visits. Under PDGM, it's going to range from 2 to 6 visits are going to be a LUPA for your patients. And that's going to be per 30-day episode. So your agency, like most, probably does front loading. When you get a patient out of the hospital, you do a lot of visits up front, and then you gradually reduce those visits through the end of the 60-day episode. What that means for your agency is a big consideration of whether you're going to keep that patient or discharge them once your goals are met. A lot of agencies will decrease for assessment and monitoring of patients in case an exacerbation occurs towards the later end of that episode. What that means now is that could be 2 to 4 visits in that second 30-day period, and as a result, you might have a 6-visit or a 4 or 5-visit threshold based on your case mix, and that ends up being paid as a LUPA, not a standardized 30-day payment period. Each of your RAPs are being reduced to 20%, and each of your final claims would be 80%. So as you know now, you have a RAP that's either a 60-40 split if it's an SOC, or a 50-50 split if it's a RECERT. CMS is trying to phase that out. In the proposed rule, they stated that they would reduce the RAP payment starting January 1st to 20%, and the final amount would be 80%. Then in 2021, they're looking at eliminating RAP payment altogether. So you would do a notice of admission within the first 5 days of your episode, and then you get 100% of your payment at that 30-day or when you file the final claim. So that's a significant financial impact that agencies have to be prepared for. And unless the final rule changes that based on user comments, you're going to get paid 20% and 80%. There were about 90 comments last time I looked on September 9th when they closed that comment period, hoping they had a rash of comments that they're considering. Otherwise, agencies are really going to suffer, unfortunately. The claim processing. Go ahead.
Sorry, for the LUPA ranges, what determines the between 2 to 6 visits?
Each and every case mix, there's 432 of them now, will determine that case mix. So your primary diagnosis code, the functional impairment, the timing of the episode, the admission source of the the payment period and the comorbidity adjustment will develop one of 432 case mix, and each and every case mix will have a LUPA threshold for it that'll either be 2, 3, 4, 5, or 6. So that case mix is what determines what that particular 30-day payment LUPA value will be.
Okay. Is there a way to find out what that LUPA number is once the case mix is determined, or?
Yes. Yep. Yeah, there is a PDGM grouper tool that CMS made available on their CMS website. If you search in Google for Home Health Agency Center, the last time I looked, which was a week ago, the very top section was on PDGM. And if you look in that top little blue kind of cartoon bubble square, the updated PDGM grouper tool is present. You would enter in that the number of visits you're going to do for that 30-day period. Make sure whoever's using that tool knows that, because you're not going to put in your 60-day plan of care visits. You're going to put in and have to analyze that and say, how many are we doing first 30 days? Rerun it for the second 30-day period. And then put in your early, late, institutional, or community, all of your diagnosis codes, and then your answers to those OASIS questions, 1033 through 1800 through 1860. That will tell you what your case mix is, and it will tell you if it doesn't develop a case mix, you know it's a LUPA value. But one of the tables, it's an Excel spreadsheet, one of those tables in that workbook will give you the LUPA ranges for the case mix. So all 432 of those, you can skim up and down and find out what the LUPA range is for that specific case mix. Does that answer your question?
Yes.
Okay, perfect. So yeah, right now there's no way to know until you know what that case mix is, what the LUPA is going to be for that.
Okay.
The claims processing itself will determine whether it's an early or late. CMS is pulling that from their common working file. The agency does have the ability of indicating whether it's a institutional or a community referral, because they now have the option of adding, or will January 1st, of adding the occurrence code 61 or 62, and then they specify what the inpatient discharge date was. If that falls within a 14-day window, then you enter that on the claim, you enter 61 or 62, depending on where that patient came from, and then CMS will then use that to total what your payment is. If you don't have that information, you don't enter that information in the claim, then what will happen is CMS will look at the common working file and pay you based on what is present there. One of the big cautions is that agencies that receive VA hospital patients and referrals, VA hospital does not report to the common working file. So for the only way to get an institutional payment from a VA hospital admission that was discharged within the last 14 days prior to your 30-day episode is to enter condition code 61 or 62 on that particular claim. Otherwise, CMS will see no corresponding claims from an inpatient facility, and you'll be paid as a community referral instead of institutional. CMS has said in the proposed rule that they will adjust that based on claims every time they receive a claim from home health or a inpatient rehab facility. They will adjust that and pay you, if appropriate, based on receiving that claim. So to elaborate on that, you may get an SOC that a inpatient facility has not yet submitted their claim. CMS, when you submit your RAP, sees that as a community referral, but by the time you submit your final claim, possibly they've submitted their claim, and CMS knows now that you're going to get a full episode payment as an institutional setting. If that is not present and you don't use those occurrence codes, then they submit their claim 60 days afterwards. You would get an adjustment in one of your following, I can't think what they're called, one of your ERAs, your remittance advice. You'll be able to see an adjustment in that payment up to the 12 months timely billing period. They'll make those changes automatically.
Okay.
So with that said, we are providing complimentary OASIS reviews, coding reviews, or full chart reviews for a 60-day episode. If you see advantage in taking that, evaluating what your staff are currently doing, We also are offering a very limited promotion ending September 23rd for a PDGM preparedness review. We will look at 10 of your OASIS codings and reviews. We'll review that and see if there's any adjustments that should have or could be made to that, and give you an estimation of what the case mix code would be, and therefore from that you can compute what you would be getting paid for those if those were admissions on or after January 1st. It's an opportunity for you to see what those values are now, so you can start budgeting and preparing what adjustments, if any, need to happen with the agency so you'll be successful under PDGM. It's a one-time fee of $455 to be able to do that PDGM review. We do that over up to a 30-day period. You identify the 10 OASIS you want, whether they're current or you want to do a review of your past coders' experience. Totally up to you which ones you pass on to us. But it's a great way to be able to see that preparedness and where you're currently at. So like I said, you can start formulating those budget values. Do you have any other questions for me, Michael, before I turn it back over to Adeline?
At the moment, no.
Okay, fantastic. Well, thanks so much for listening to us and sharing part of your day with us.
Oh, thank you so much, Michael. I appreciate it.
Yeah, and Mike, I just wanted to say thanks for your time too. So I also wanted to just kind of give a little input. I've been on these calls with Michael for a while now, and we've been using this analogy with some of our clients. So imagine you're going on this long road trip. You've known about it for some time, but you didn't take the time to make sure, like your car's engine was running properly, didn't get the oil change, levels checked, etc. So this long trip, it finally rolls around. Now, outside of being overwhelmed with getting people to arrive on time, getting that car gassed up and packed, worrying about when you'll actually get on the road, how much of the trip you'll be able to cover, now you're also starting to stress about the engine, the suspension, the oil change, the tire pressure that you never got around to checking. Now you're thinking to yourself, should have, would have, could have. And not just for you, but everyone else that's going to be involved in any of those worst case scenarios if they happen to play out. So we definitely don't want this playing out for you or your staff with PDGM, and it's coming up fairly quickly. And we definitely don't want your future self saying, I or we should have prepared. So if you give us the thumbs up today, we can make it easy for you. We'll go ahead and sign you up for the PDGM Preparedness Review promotion that Michael mentioned with just a verbal approval, since we already have your agency information for billing purposes and a credit card on file. How does all that sound?
Give me 1 second. I actually can't make that decision. Give me 1 second. Let me talk to our owner really fast.
Okay, awesome. Thank you.
Thank you.
Your call is very important to us. Please continue holding so that one of our representatives may assist you.
Hi, Lee.
Yeah.
Hi, so sorry about that. He's actually on his phone at the moment. Is there a way I can give you a call back on that one?
Yeah, definitely. You could give me a call. And if I don't hear from you, would it be okay for me to give you a call back tomorrow?
Oh, for sure. That wouldn't be a problem. I should be able to give you a call back in the next 20 minutes or so.
Okay.
What's the best number for me to call you back?
Okay, so you can reach me. Let me give you the full number. It's 714-229-8700, and my direct extension is 137. And then if you had any other questions pertaining to the actual information that Michael shared, he's more than happy to answer, more questions that you guys might have, and he can be reached at the same number, but extension 120.
120. Now, the presentation that was given, what do you call it? Is there a way to be able to view this offline as well?
Yeah, we went ahead and recorded the presentation too. So what I could do is, after the call, let me let the recording render, and as soon as the recording is rendered, I'll put it up on a site so that we can give you a link and you can take a listen to it.
Okay, sounds good.
Okay.
Perfect. So let me just talk with him, and then I will give you a call right back and let you know what he says about the review portion.
Okay, great. I look forward to hearing back from you.
Thanks, Adeline.
Thanks, Michael.
Thank
Take care.
you.
Bye-bye.
Thanks, Michael.
Bye-bye.
Bye-bye.